Hi everyone online. Every doctors come from lots of countries. I'm one of the two moderator, Dr. Wang Xiaoting. I come from China. I'm a Chinese ICU doctor. Today there's two moderate. The first one I will introduce myself. I am the director of Chef ICU, deputy director of Department of Critical Care Medicine. I come from Peking Union Medical College Hospital. I am the executive chairman of Chinese critical ultrasound study group, that is to see CCUSD. I am the president of Beijing Research Association on critical ultrasonography. And it's my pleasure to invite the other moderate, Professor Dr. Cao Yangong. Let him introduce himself.
Okay, thank you, Xiaoting. Hello, everybody. I'm Dr. Yangong Chao. It's grateful to be here to talk about COVID-19 epidemic. I hope that we can give some useful information to our international colleagues to fight this disease together. And in China, we almost conquer this kind of disaster, but in the whole world, we hope we can do something that's useful. Thanks.
As we all know, unexplained virus pneumonia in Wuhan, China was later identified in December 2019 as being caused by the novel coronavirus. The COVID-19 outbreak is rapidly evolving and spreading in an unprecedented way in China and other countries in the world. So far, it has produced over 100,000 confirmed cases, and the incidence rate of critical cases is over 10% or more. So the epidemic situation is an order of command, and the ICU physicians fearlessly joined in the fight against the virus, the disease, COVID-19. Based on the recommendation of the national-wide ICU experts involved in the fight against the epidemic in Wuhan, Hubei province, we summarized the guidelines, the recommendations for using critical ultrasonography in diagnosis and treatment of severe COVID-19. We're hoping to help facilitate the treatment of severe COVID-19 patients. It's our honor to share our experience with every doctors from lots of countries online. So we will say sorry to everyone online because the scheduled speaker, Professor Yin Wanhong, have the patient need to treatment, need to rescue. So in Wuhan, so we changed the sequence. We changed the speaker from Professor Yin Wanhong to Professor Zhu Ran, and his name. His topics, his theme is respiratory management with critical ultrasound, maybe critical ultrasonography for COVID-19 patients. Let's begin.
Hello, everyone. Good afternoon, my friends from Italian and European countries. And good evening, my friends from Korea and Asia. I'm Dr. Zhu Ran, or Ranzhu, or Dr. Zhu, as you like. I come from the first affiliated hospital of China Medical University, Department of Critical Care Medicine, Today, I'm gonna talk with you about my experience or our experience with combating COVID-19. I will focus on respiratory management in critically ill COVID-19 patients. And my colleague, Dr. Chow and Dr. Yin will cover the content of imaging characteristic of COVID-19 and hemodynamic management of COVID-19 patients in the following days. So let's start today's topic with these numbers. As we can see, new infections in China and outside China shows different direction of the curve. It's especially severe in Italy and Korea, just like which was the situation in China 1.5 months ago. By now, we have over 80,000 infected patients altogether in China, and over 3,000 patients died. So we are all facing the same kind of critical situation in fighting COVID-19. Now I work in Chaoyang Hospital since 3 weeks ago. It's in northeast of China, Liaoning province. Altogether, we have 125 confirmed COVID-19 cases in this province, with 3 critical cases, 2 on ECMO and 1 weaned from both ECMO and mechanical ventilation, discharged last week. This is a 3-level A hospital with 1,200 beds, and they opened a new building with a new PICU used for this separated critically ill COVID-19 patient, and which is our main task and responsibility now. We sent a combined critical care team, mostly from my department and my hospital, from the moment this patient was on ECMO. And you can see the picture. This is me, who is in charge of the medical team now and have the background of critical ultrasound training and FCCM. This is a picture of going rounds with doing critical ultrasound. And that is my critically ill COVID-19 patient who was deeply sedated, mechanical ventilated with ECMO, CRT, and so on. A couple of weeks ago, our government published the guideline for COVID-19 in English version. We used to call this disease NCP for novel coronavirus pneumonia, and now we move to COVID-19. I will go through the items simply with some of the newly published information of COVID-19, and then we will move to the respiratory management of critically ill COVID-19 patient. As we all know, I guess, the incubation of this disease could be 1 to 14 days, with a mean 4 days almost. The mild and ordinary type could only present with the signs and symptoms of fever, non-productive cough, and fatigue. Imaging of pneumonia on CT scan. In severe and critically ill patients, severe acidosis, coagulopathy, acute exacerbation, sudden arrest, MODS would all happen. But for most of the patients, we know that the prognosis is quite favorable, except for elderly patients and patients with comorbidities. For lab data, a normal or decreased white blood cell and decreased lymphocyte, elevated CRP, muscle enzymes, troponin I, liver enzyme, and of course, they will have positive nucleic acid. We know Dr. Cao Bin from China just published a retrospective study of COVID-19, and the results showed that an elevated D-dimer over 1 would be a prognostic indicator together with age and SOFA score. And someone who could test for the cytokines tell that there would be elevated inflammatory factors. Chest imaging. Chest imaging is the most important examination. for both diagnosis, evaluation of the disease process, and also be included as one of the criteria for discharge. We could find multiple small patches, especially in peripheral of double lungs. The area and density of the foci could develop into consolidation, but there will be rare pleural effusion. I will show you CT scan from my patient in the early stage. This is a CT scan on the second day of the onset. As you can see, the foci on the left side. And this is a CT scan 1 week later after the last one. We could see the development of the pneumonia in both lungs. And that would be 1 day before intubation. We also have a guideline of chest image of COVID-19 in China. As we can see here, we might use lung ultrasound to examine our confirmed or suspected COVID-19 patients according to the CT scan characteristics. My colleague, Dr. Chow, will give a speech on this aspect this Sunday, so I'm not gonna talk about it in detail. But we do recommend to use lung ultrasound dynamically, which means we could find the worse or better signs with lung ultrasound and helps us to make clinical decision, as you can see in this figure. So we confirm COVID-19 infection with epidemiology, clinical manifestation, lab result, and the CT scan of the chest, and of course, a positive nucleic acid. But I know the nucleic acid test is very expensive outside China, and the test could not be enough in this moment when there is a big outbreak. We should always classify COVID-19 patient according to the severity. And in China, doctors with a training background of critical care medicine are required to manage severe and critical COVID-19 patients. And doctors without critical care medicine background could only deal with mild and honor patients or work in fever clinics. About the stage of the disease, we don't have a clear definition, but now most of the patients come to a subacute phase with a poor pulmonary function, maybe fibrosis, and might be waiting for the lung transplantation if nucleic acid test could become negative. I know there are 3 pathological publications as I know. These are biopsy from 2 patients admitted to hospital for surgery of lung cancer without knowing infection of COVID-19. We could see in this early stage of COVID-19, there are marked exudation of protein and fibrin, thickening and fibrosis of alveolar wall and septum without inflammatory components. And these are from autopsy for an elderly COVID-19 patient with comorbidities. We would find macrophage and lymphocytes infiltration in both lungs, and we could find some light changes in heart and the liver tissue on the right. And the third, this double lung biopsy from the first attempted lung transplantation in Shenzhen in a COVID-19 patient, although the patient passed away after transplantation. We could find necrosis of epithelial cell of bronchi and alveoli inside the lumen, and the thickening of alveolar septum in the interstitial tissue, we could find fibrosis together with hemorrhage and infarction of the small blood vessel. And let's reveal the first pathology in the world of ARDS. There are striking alveolar atelectasis and engorgement of capillaries, also hemorrhage and edema, hyaline membrane formation. So I'd like to ask all of you a question. Do you think critical COVID-19 is ARDS? They do have something in common. On the left, I write there, DAD, which means diffused alveolar damage in pathology. That's what we have now. They all have reduced lung mechanics, which means compliance. They all have severe hypoxia, might be the mechanism of VQ mismatch. But what I found, there will be some different on the right, which means the consolidation in COVID-19 patient may be not so much consolidated, which I call it sub-consolidation, which means less atelectasis of the alveoli. And I found the capillary permeability in COVID-19 patient is not so high, except for complicated with some secondary infection in the lung. So we could use lung ultrasound at the bedside to find there is less inhomogeneity in this kind of critical COVID-19 patient with respiratory failure. And we could find there might be normal extra lung organ function in this kind of critical COVID-19 patient. So that's quite different from what we are familiar with. The original ARDS patients mostly come from sepsis-induced ARDS. So I would rather call this critical COVID-19 patient ARDS mimics. We need to recognize the severity is similar to ARDS, and also COVID-19 patient could progress to or complicated with ARDS, but they might react differently or quite differently to ARDS respiratory management. For example, not good reaction to RM, that means recruitment maneuver, not a good reaction to PPV, that means pro-positioning ventilation. So pathology or imaging could tell us how severe the patient is, but usually we could not have a CT scan every day, and chest X-ray could be done every day, but it could not tell us the truth. So lung ultrasound and also critical ultrasound to evaluation of different organs could tell us a lot of information of pathophysiology in COVID-19 patients, especially when we are under 3-level protection. This is how I go rounds every day using critical ultrasound to evaluate the lungs, the fluids overload situation, the hemodynamics, together with other parameters I could get from the clinical to make everyday clinical decisions. Of course, I also use critical ultrasound to examine GI movement, to direct a jejunal tube insertion, to examine for DVT every day, check the eyes for ONSD when patient is deeply sedated, check the kidney for perfusion, and check the diaphragm for the movement, and so on. Management of COVID-19. Generally, as we can see, and we might all know, including antiviral, most of the therapy in the upper side of this slide is not sure. And we could only do the best part of critical care medicine, which means monitoring and supporting our patients, such as sedatives, starting nutrition, preventing DVT, optimize the fluids in the patients, and treating, evaluating the underlying disease of our critical ill patients. We do have different modalities of respiratory management, which means oxygen therapy, high flow nasal cannula, non-invasive ventilation, invasive mechanical ventilation, and ECMO. But we don't have a clear indication or protocol for choosing or changing this kind of or modality of respiratory management. So COVID-19 is new to us. But what I think is respiratory failure, ARDS, the pathology and clinical management is not new to us. So we need to do is what we used to do plus what we know from COVID-19, the new pathophysiology. So I would like to recommend 10 key points to share with you in respiratory management of critically ill patients. I will explain one by one. First, focusing on hypoxia as much as you can. No matter how mild your patient is, especially when you don't have a pulse oximetry monitoring every time and there are not enough critical care staff, the patient could get a sudden exacerbation and cardiac arrest just because of hypoxia overlooked. So we need to know hypoxia could damage all organs, especially in the heart, the lung, the brain, and so on. So it could cause cardiac injury, pulmonary hypertension, brain hypoxic injury, and it might not be differentiated from the primary viral injury. Another reaction to hypoxia is the respiratory system and circulatory system. We could find a very strong spontaneous breathing with increased respiratory rate and a hyperdynamic heart. Both oxygen consumption in respiratory muscle and cardiac muscle increased, and which will become a vicious oxygen delivery consumption cycle. And as we know from the pathology and imaging of COVID-19 patients, we guess or we think diffusion impairment could be the first mechanism responsible for the hypoxia in COVID-19 patient, and VQ mismatch and intracardiac right to left shunt could happen when the patient progressed or complicated with ARDS. So when talking about hypoxia, we need to know the different organs are all affected by hypoxia. And we need to be clear about the pathophysiology of the hypoxia in your patient. We need to maintain or keep the consistency of oxygen therapy. It could be well done. For example, when the patient is leaving for toilet without a pulse oximetry on his finger, without the oxygen therapy during the toilet time. So it could be overlooked and without monitoring and with the shortage of critical care staff. So if you put your patient on a hypoxia re-oxygen therapy situation, is similar to give oxygen stress to your patient. Of course, we need to set a target of oxygenation. From my point of view, I'd like to make the saturation of oxygen over 95, which means my patient will have a better oxygen reserve, especially before or during his activity. And one key point to dealing with the hypoxia is to reduce oxygen consumption. We could do that or practice that in two ways. The first is from the systemic aspect. We could reduce all the activities, all the stress, all the body temperature as possible as we can and as possible as the patient can. And from the regional aspect, we need to focus on the myocardium and respiratory muscle, which means you need to reduce the heart rate and contractility both in your muscle, cardium, and respiratory muscle. Next one, management and titration of spontaneous breathing. We are familiar with ventilation-induced lung injury, but might not be so familiar with spontaneous breathing-induced lung injury. As we could see from these curves, the spontaneous breathing may cause an increased transpulmonary pressure. So as these figures we are all familiar with, on the lower right one, when the patient is in the situation of spontaneous breathing, and especially in the hypoxia and respiratory distress situation, you could see even if you maintain the pressure in your alveoli very low, that the pleural pressure in the thoracic cavity could decrease to -30 to -40 centimeter water. So the transpulmonary pressure could increase to over 40, even 50 centimeter water. So that definitely will cause the injury to the lung, especially to the alveoli. From another aspect, as we can see from this figure, so the decreased pleural pressure can also cause an increase of transvascular pressure in the capillary in the lung. So the spontaneous breathing may cause the water in the lung, the free water or the extravascular lung water increase dramatically. So we can see, as we know in this pathology, if the patient has ARDS in a mild type, a spontaneous breathing will be beneficial for the patient because it will help with the VQ match. But if the patient is in severe lung injury, severe ARDS, strengthened spontaneous breathing will damage to the lung, will give the lung additional lung injury. So dealing with spontaneous breathing, we need to focus on the additional injury it gives to the lung. So we need to manage the spontaneous breathing. And we need to know the mechanisms why spontaneous breathing becomes strong. So there might be some mechanisms like hypoxia, but you could see some of the patients still in a strong spontaneous breathing situation, even when the hypoxia is improved. So the enhanced stretch reflects the enhanced sensitivity of J receptor in the pulmonary capillary. Will have some mechanism in this one. So do we have some indicators or parameters or methods to monitor the strong respiratory drive? Maybe. So we could use ultrasound to detect the strong diaphragmatic movement, which means in distance and thickness. We could use imaging to find how severe the pathology is, and most direct, if we put a tube in the thoracic cavity, we could read the pleural pressure directly. And the PPV and IVC change may tell us how dramatically change in thoracic cavity. That means an indirect measure of pleural pressure. And if you dynamic evaluation your patient's lung with ultrasound, you might find the water in the lung increase may be a reflection of the spontaneous breathing induced lung injury. So we could dealing with the spontaneous breathing by improvement of hypoxia, but sometimes or always we need some sedatives, maybe combined with muscle relaxant. Mechanical ventilation, that's what we are familiar. And we are familiar with ventilation-induced lung injury in this 50 years of recognition of ARDS. But in your critical COVID-19 patient, you always have a static compliance lower than 10. So to keep a safe plateau pressure lower than 28, maybe you need to set your tidal volume lower than 100 mils, which means lower than 2 mils per kilo ideal body weight. So could that meeting your sheeting targets? Could you make a balance between the safety and the effective ventilation? Maybe we couldn't. And we need also know the ventilation may cause a cyclic interruption and exaggeration of the flow to the pulmonary microvascule. So it could also cause the injury to the alveoli and macrovascule. So the basic rules for mechanical ventilation, we need a protective ventilation. And we now have an advanced protective ventilation, which means the right ventricle protection ventilation. We could do recruitment maneuver to our patient, but as we talked before, the inhomogeneity, the capillary permeability in this kind of patient is not as much as ARDS patient. So you need to evaluate the recruitability in your critical ill COVID-19 patient before you practice RM, and usually you will find your critical COVID-19 patient react not so good to RM. And thirdly, spontaneous breathing-induced lung injury, keep that in mind always, no matter your patient is on an IV or invasive mechanical ventilation, because it's very strong. You need a big amount of sedatives and muscle relaxant to keep your spontaneous breathing not so strong. And of course, we critical care practitioners always set a target for our every movement. So the target of the mechanical ventilation, we need to set according to different stage, which means at the beginning of mechanical ventilation, when there is complication, which means, for example, the pneumothorax, the ACP, and if the patient are put on ECMO and during the weaning stage of the disease, we might have different targets to set the mechanical ventilation. And infection control, that's very important, of course, because an additional ventilator-associated pneumonia will give the patient a more complicated situation and even harder to treat. Management of hemodynamics. We know in our critical ill patient, in ARDS patient, in patient admitted to ICU, there are very common in changes in hemodynamics, but we have to say that in COVID-19 patient, especially in mild and ordinary COVID-19 patient, and even in some severe, not critical COVID-19 patient, we could not observe dramatic change in hemodynamics, but we do find that there will be a hyperdynamic status. That's very common. Maybe it's a reaction of the circulatory system to hypoxia and to this disease. So to manage the hemodynamics, of course, we need to reduce the body requirements for the cardiac output. So to maintain or control the body temperature, to inhibit sympathetic excitation, and to control the respiratory muscle oxygen consumption. That's very basic treatment to management of hemodynamics. And we need to recognize the hyperdynamic status has injury to the lung or has injury to the pulmonary circulation. So we know that a high cardiac output, the hypervolemia, the pulmonary hypertension, that will be harmful to the patient's lung. So using an echo, using critical ultrasound at bedside to evaluate the patient's cardiac function, chronic, both chronic and acute, that's very necessary. And ACP, we will talk it later. So we know from some article revealed that maybe a therapeutic hypothermia will reduce the instance of ARDS in some kind of patient and maybe deliver less calorie to your ARDS patient will reduce mortality. And of course, less fluid in sepsis and also in other patients will always be beneficial for ARDS patient and for respiratory failure patient. So we need to optimize our fluid status in our patient. And for the cardiac output in the pulmonary circulation, we know from the experience of post-cardiac surgery patients, if the post-cardiac surgery patient has a lower ejection fraction, they may have a higher mortality. They may have a lower instance of ARDS. That's very interesting. You need to consider or you need to think about that situation or that parameter when dealing with your severe or critically ill COVID-19 patient. And dealing with hemodynamics, you need an echo. If you evaluate your patient in this way, you could find chronic situation with an enlargement of the ventricle, thickening of the ventricle wall, and that will give you the alarming when dealing with a patient, especially with the fluids. And you could find this chronic right ventricle dysfunction in your patient, and you could find this chronic left ventricle diastolic dysfunction also in your patient. And for the acute change of the cardiac function, if you do an echo thoroughly, you may find the etiology underlying the acute change in cardiac function. The most common situation, the most common status we found in COVID-19 patient is a hyperdynamic status of the heart, just like the upper right movement. And almost always in all COVID-19 patients, especially with the severe COVID-19 patient, and especially with the hypoxia COVID-19 patient. And also we could find some of the patients with stress cardiomyopathy. And after some cardiac arrest or some complication, we could find the hypodynamic in both left heart and right heart. And as we know, there will be a poor prognosis in the elderly patient. So we need to check for coronary disease. So that means coronary segmental movement. And when the patient is complicated with shock, echo should be the first one to make differential diagnosis. Monitoring and management of ACP. We know that there are a lot of mechanisms responsible for the ACP in ARDS, such as microthrombi, hypoxemia, hypercapnia, edema, or distension or loss of lung volume in regional and systemic way. And we also know that as severe as the damage of your lung, as severe as a pulmonary hypertension will be. So we could compare our own critical COVID-19 patient to this table. They have a pneumonia. They always have a driving pressure over 18. They have PF ratio lower than 150. They have a hypercapnia with a carbon dioxide over 50. That's very common, almost 4 of them in our severe or critically ill COVID-19 patient. So an echo checking for ACP should not only be necessary, it should be routine every day, every time the patient's situation change. So if you really check your patient with echo, sometimes you will find your patient with this kind of situation, with this kind of change of your heart movement. And sometimes maybe you could find the intracardiac right to left shunt, which may responsible or which may explain the refractory hypoxia in your patient. So dealing with ACP, we need to know there will be ACP in your critical ill COVID-19 patient. So you need a dynamic day-by-day echo monitoring to know if it is onset and to know the severity it is. And to manage the ACP, we need to know what we can manage from the mechanism. So a better FRC to decrease the inhomogeneity, to decrease the respiratory drive, and to control the environment, which means to reduce hypoxia, to decrease hypercapnia, to improve the acidosis, and to anticoagulation, to treat the thrombosis, and even the control of left ventricle function, to make an optimization of fluid to control the pleural and the pericardial pressure will help. Propositioning ventilation. When we use propositioning ventilation in our ARDS patient, our group will use lung ultrasound always in the dependent and non-dependent region to find the inhomogeneous situation in our patient. So if we do the lung ultrasound scoring in our patient, we could make a prediction of the potential of prone positioning ventilation in our ARDS patient. And that is very necessary. And the propositioning ventilation, it is very useful, effective, and now we know that it is also a right ventricle protection ventilation, which means if your patient have ACP, or is going to have ACP, you need to give him propositioning ventilation in advance, maybe. And we know propositioning ventilation may cause the change in hemodynamics. So the evaluation before, in, and after the propositioning is very important. And usually we do that with our echo and lung ultrasound. And you need a well-organized critical care practitioner team. But when the shortage of critical care background staff, so the first rule is to keep the patient safe. Propositioning ventilation in COVID-19, is it necessary? Yes, definitely it is necessary. But I think the first mechanism for propositioning ventilation in COVID-19 patient is for drainage, to drain the secretion in the bronchi. Because our patients are all on deeply sedation, all have the possibility of hospital-acquired infection, so the drainage is much important, so it's necessary. And it could be less effective in COVID-19 patient because we know it's like a fibrotic change. It has less inhomogeneity in COVID-19 patient, but it could become effective when there is higher inhomogeneity. For example, the patient is complicated with hospital-acquired infection, complicated with sepsis, complicated with fluid overload. So we need to evaluate the feasibility and the potential of proposition ventilation. And we need a well-organized ICU medical team. When there is shortage of critical care staff, safety is the first rule. ECMO. We know some of the patient, the critical ill patient, mechanical ventilation could not meet the ventilation target of this kind of patient. So ECMO is necessary, but we need to give a safe ECMO placement in all our patients because they are so severe, so critically ill. So as we know, we would like to recommend an ultrasound assisted visualized placement of the cannula. And we can find some evidence from the papers. And we need a thorough examination for respiratory system together with circulatory system to choose or find the timing to change the modality of ECMO, which means VV, VA, or VAV. So I will give you an example from my patient. You could see that the red arrow, it indicates the draining tube of the ECMO cannula. And at first, because we didn't have the echo and we didn't have X-ray at the first moment, so in the first 24 to 48 hours, we couldn't get enough ECMO blood flow for this patient. We could make an adjustment when we get the echo at the bedside, and then we adjusted the depth of the cannula into almost 1 centimeter into the right atrium, and then we get enough ECMO blood flow all through almost 1 month. And in this critical ill patient, COVID-19 patient, the hypoxia is very severe. So the drop of the blood flow in the ECMO system will cause both the respiratory and the circulatory collapse in this kind of situation. So it's very severe and critical. So we'd like to recommend a visualized insertion of the cannula to maintain the safety of the patient, a visualized localization of the cannula to make sure the blood flow in the ECMO system, to visualize your heart and lung function, to choose or making change of the modality of the ECMO, and to optimize the oxygen delivery and consumption every day, every moment. And we also need a visualized and protocolized weaning from ECMO. So protocolized weaning of mechanical ventilation and ECMO. Actually, we don't have a protocol, a clear protocol of weaning mechanical ventilation or ECMO, but we do have some criteria we need to consider about. First, we need to evaluation of COVID-19. This disease is a viral stop replication, so the nucleic acid should become negative. Second one, evaluation the clinical manifestation. The fever maybe reflect the inflammatory status, reflect the oxygen consumption of the patient. And the third evaluation, the image. The image is always very important because it could show the pathology of the patient's lung. And the last one, to evaluate the pathophysiology. That means you need a lot of parameters. PF ratio maybe, respiratory rate maybe, but we all know that's not sure. And you need still keep in mind that a strong respiratory drive will harmful for the patient at every moment. So protocolized weaning from MV and ECMO, you need to, according to your own experience and according to your individualized patient, but we do recommend to visualize the process of weaning from mechanical ventilation and ECMO. External organ support. The mechanical injury, mechanism of injury to extra lung organs, we don't know, but we do observe the extra lung organ function keep normal in most of our patients. That if it happens, it might be the viral infection, but we are not sure. It might be the chronic dysfunction of the patient. It might be the reaction to the hypoxia, the reaction to the inflammation, and it could be the hemodynamic disturbance, and it could be the iatrogenic injury, for example, Willi and Silly. And the management of the extra lung organ support, the basic rule is to manage your heart and lung and to maintain the best oxygen delivery to minimize the injury from hypoxia. And we could use the ultrasound to monitor perfusion and function of each organ. PICS. PICS here does not mean the post-intensive care syndrome. We use PICS here to indicate the persistence, inflammation, catabolism syndrome. So we are all familiar with these curves, which means the long stay in ICU over 10 days, over 2 weeks. They could have some hospital-acquired infection. They could be in a status of malnutrition. They could have some progressive immunosuppression. So we know in COVID-19 patients, such as my patient, has over almost 40 days and 30 days on ECMO. So the COVID-19 might have a longer process, maybe over 4 weeks or more will stay in ICU. So we need to deal with the inflammation and the immunosuppression, the balance between stress and sedatives, prevention of DVT, starting nutrition and starting rehabilitation, and we need to recognize the prolonged cognitive function and psychological problems. And the last one we are not sure about is the pulmonary function evaluation for the long stayers for the prolonged COVID-19 patient, if there is refractory fibrosis or not. So transplantation, we don't know to do or not to do. To conclude, COVID-19 might be different from ARDS in homogeneity, in capillary permeability, and COVID-19 could be a long process, so you need to focus on some Higgs syndrome. Recognition and management of hypoxia in COVID-19 patients always be the first key points. Keep that in mind. And the recognition and management of the strengthened spontaneous breathing to avoid additional injury to the patient's lung. Optimize the hemodynamics, monitor for ACPOS, and cautious when weaning from mechanical ventilation and ECMO. We do recommend critical ultrasound to visualize the pathophysiology in COVID-19, especially in this 3-level protection environment. And we have recommendations for treatment of critically ill COVID-19 patients based on critical care ultrasound from CCUSG. And we got our papers accepted and going to be published by Chinese Journal of Internal Medicine. And we group pre-published online with mp.weisin.qq.com. As I think there might be some time left, so I will give a short case of my patient to you. So this is the timeline of my patient and their treatment. So altogether, the onset of COVID-19 for my patient is over 40 days. And the patient got critical and intubation and mechanical ventilated over over 30 days, and the patient was on ECMO for almost 30 days. And now he is on ECMO, deeply sedated, mechanical ventilation, plus CRRT, and we could see most of his relatives have COVID-19 also. And his son, his little son, was also the critical COVID-19 patient and was also on ECMO, but he was weaned from ECMO and mechanical ventilation and discharged to home last week. And this is a CT scan on the second day of the onset of COVID-19. So we could see the foci on the right lung and on both basal lungs. This is another CT. 5 days later, we could see the development in both lungs. It's obvious in the right lungs. Obvious in the basal lungs. And this is the last CT scan we could get before intubation. And this is 9 days after onset of COVID-19. And we could see almost a diffused pathology in both lungs. The patient developed very rapidly, and then he got intubated after this CT scan. And 3 days later, he was put on ECMO. So treatment, we give this patient antiviral with Abidol and chloroquine. We didn't observe the side effect of chloroquine, but the nucleic acid in my patient, although over 40 days of treatment, is still positive. We give the patient IVIG steroids at the early stage. We give the patient convalescent plasma, altogether 600 mL, as soon as we can get it. And we put the patient on CRT plus inflammatory absorption and PA when inflammation became obvious. And we gave the patient Chinese traditional medicine in early phase. But still, the COVID-19 disease progressed. And this is the bronchoscopy of my patient. You could see the mucosa, the bronchi, almost normal. And we didn't find a lot of secretions in the bronchi. And this is the latest X-ray, chest X-ray. Maybe you couldn't find any difference between these 4 chest X-rays, but if you do the lung ultrasound every day, maybe you could see on the right and on the left, the consolidation thickness become different. And this is the parameter, the setting of the mechanical ventilation and ECMO, the movement of the GI tract, the cardiac output of my patient. Prognosis, I don't know. I'm waiting for the nucleic acid of my patient to become negative, but I don't know how long. I try to optimize the oxygen delivery and hemodynamics every time, every moment, every day. I try to make a best infection control, which seems a little bit easier because we have a new intensive care unit. There will not be some environmental bacteria there, and we try to avoid villi and cilia as much as we can. And we are waiting for lung transplantation, which I don't know. So thank you, all my friends. I'd like to close my presentation with the words from our President Xi Jinping. No victory should be lightly announced until it is complete. So let's combat COVID-19 together. Thank you.
Hi everyone. Every doctors, especially ICU doctors. Let's say great thanks to Professor Zhu Ran. She took a great lecture on the severe, maybe critical COVID-19. Let's say thanks to her again. Then we will answer some questions we can see in the center box. There's lots of questions. We maybe choose some important question to some doctors working in China, maybe in Wuhan, in Hubei province. So the first question, maybe I will invite the Professor Zhu Ran to answer this question. The question is anti-SARS-CoV-2 IgG and IgM assay qualitative and semi-qualitative test IgA dosing experience.
Okay, thank you. I will take this question. We only have this kind of examination just recently in the last 2 weeks. I tried that serodiagnosis in my patient twice, which was in his late stage of the acute phase. It is a qualitative examination, which looks like you can have a dark red line for the control, and you will have a light or dark line for IgG or IgM. For my patient, I only have a light red line for IgG. That's my answer. Thank you.
Thank you. There's another question, maybe the second one. It's a very interesting question about the critical ultrasonography. The question is, what are the most typical sonographic characteristics of COVID-19? It's a question about the COVID-19 and the critical ultrasound. I will answer this question by myself. I will tell everyone about this. The longer ultrasound features of COVID-19 are related to many factors, including the stage of disease, especially. That's the key point. And the second key point is it's related to the severity of pulmonary involvement and the underlying disease, etc. In the longer ultrasound examination, it is easy to find or maybe discover as marked lesions are mainly distributed subplural. It's the key point too. So COVID lung ultrasonography has following characteristic. Just like the first one is pleural thickening. because the virus is very, very small. We will be inspired to the very deeply to the lung. So the pleural thickening is very often in the lots of the patients. The second one is the different degree of B line, just like B7, B3, and the fusal B line, including focal B line according to the distribution area. The last one, but not the least, there's lots of other features about the longer ultrasonography features in the COVID-19. There's some just like subpleural consolidation and fragmentation signs. There's rarely with jellyfish sign. Maybe in the next course, Professor Cao Yangong, maybe take a lecture about the ultrasonography features of the lung of the COVID patients. So I will here. I just take a emphasis on the last points. Just like it should be pointed that for the deeply local lesion and all when pleural is not involved, and lung ultrasound is limited, especially for onset and mild condition cases, maybe the mild patients. That's all. There's another question in the chat box. I can see the third question is when will ultrasound be used? Can it be used routinely? I will invite the Professor Zhu Ran to answer this question, please.
Okay, thank you for the question. As you can see in my slides, I actually answered this question. I will use it routinely. And when I go rounds every day in the morning, or every situation happened at any time of the day, my colleague and I will use ultrasound to examine and to evaluate the hemodynamics or the respiratory system and even the kidney or stomach and so on. So for the whole system, we will use the critical ultrasound to examine for our brain, the blood flow in our brain and in the kidney, the GI movement and the respiratory system and hemodynamic system. And even we will use ultrasound to detect the diaphragmatic movement, the muscle, and so on. There's something left. For the control, the infection control, and the disinfect of the probe, we will do as we do in our ICU. And we will leave the ultrasonic machine in the quarantine room. So it is specially used for the quarantine patient. Thank you.
Professor Zhu Ran, I want to have a little question for you. Just like in the very beginning of the COVID-19 patients, in the very beginning, onset, do you use the ultrasound to find some to do the longer lung ultrasound examination for the patient in the very beginning, onset?
If I have this kind of patient in my hospital, definitely I will do that. But as I show you the figures in my slides, we don't have much COVID-19 patient in my hospital and not so much of critical COVID-19 patient in my hospital. So if I got a newly on-site COVID-19 patient, I will examine both with lung ultrasound and other critical ultrasound to examine for the chronic status of the cardiac function, and the lung ultrasound to examine for the primary injury by the virus or some secondary injury from maybe our treatment or complicated with sepsis and so
on. Thank you. Other question. Is there a specialist, maybe the infection control specialist, to monitoring you, maybe your colleagues, to do everything? Maybe there's some infection control specialist?
Yeah, of course. As far as I know, in each COVID-19 medical team, there should be, or it is required, an infection control specialist in the team, at least one. And they are control of the infection or the infection from medical staff to medical staff or from the patient to medical staff of the COVID-19. But for this kind of hospital-acquired infection, maybe they are not specially there for this.
If you do the echo for the patient and nearby, there's a specialist for infection control?
I think he will only examine my 3-level protection.
Okay, thank you. It's a turn to Dr. Chao to answer the next question. Maybe in the chat box. Dr. Chao, hi, it's your turn.
Okay. I will take the question. I think the first is the question is I think it's from some European country doctors. His question is, we want to know if you use a CT stratification and if you, in your experience, is safety to send home. I think it's a common question. I think Dr. Xiaoting can give us some answer. Would you please to give answers?
That's quickly transmitted to me, just like SARS-2 virus. Like
maybe I can give some of my ideas. I think yes, we in the first stage in Wuhan and in Hubei province, doctors don't have some kind of very standard criteria to give the diagnosis for this kind of disease, and doctors don't know deeply about this patient, this disease. So firstly, they use a CT scan to see what happened with the lung injury and what's the degree about the patients. So they use this machine to stratify the patients at a different level. And also, as you heard before from Professor Zhu Ran, she said that they use kind of assay or laboratory test or POC test to give some answer from IgG, IgM, or also maybe a nucleic acid test, something like this. Nowadays, Chinese doctor use some we call NAT to just to answer this question. If we can send patients to home, this is the first, and also we also integrate some clinical information. Something is patients still have fevers, X-ray, and some signs or the other things, symptoms with the patients with the disease, and to see if the patient can send to home. I think this is my ideas. What about your ideas about this question?
Because this is it's a important question about the CT scan. The value of CT scan in the diagnosis of COVID-19 in the very beginning. So I want to tell everyone about it's very, very important. If you can to make a decision, the last diagnosis of COVID-19, there's including four points. Just like the first one is epidemiological history. It's very important. And the second one is the clinical manifestation, just like fever and respiratory failure, respiratory difficulty. And the third is nucleic acid test. And the last one, but not the least, it's CT scan. Especially is slight slit CT scan. More slight slit, more important. So 2 of 4 key points is very important, very, very important. just like what the doctor Paulo mentioned, CT scan and the nucleic acid test is 2 key points above the four. So we can find some patients have the epidemic history, have the clinical manifestation, and CT scan is positive, but the nucleic acid test is negative. So we will take more attention to these patients. Stay here and stay in the hospital, stay fixed room. That's very important. And some patients have the epidemic history and have the clinical manifestation, and his nucleic acid test is positive, but the CT scan is negative. The equals 2. The equals 2. The CT scan, the nucleic acid test is negative. So 3 of 4 is positive. It's very important to make a diagnosis to the patient, just like high suspected COVID-19. So that's my point. That's my ideas about this patient. This question. That's
okay.
all.
Thank you, Dr. Xiaoting. And there's the next question is what is the incidence of the pregnant woman infected? Here in the charting room, not only Dr. Xiaoting, Dr. Zhu Ren, and me, and also we involved some of our very close colleagues, and Dr. Zhang Lina and Dr. Yin Wanhong is also here. But because of this kind of some technical issues, they can't give you a face, you can't see them, but they also have a lot of experience to treat our patients. So I think this question can give Dr. Zhang Lina. Can you give some of your ideas? Please, Lina.
What pregnant woman?
Yes. What is the incidence of a pregnant woman infected?
I don't know. I don't know the detail. I don't know the detail, but I hear about one ward from Heilongjiang province working in Wuhan. One of the ward he just to have this patient such as pregnant woman, and the 42 patients from the last month to today. It's all of the patient is arrived. So I think it may be also some patient that's the pregnant woman will to have the have this COVID infection, but maybe all of the this patient is recover from the COVID-19, and from now we can't hear the died of this kind of patient.
Okay. Thank you, Dr. Lina. Let's select the next question. I think this is from maybe Middle East Asia, the doctor. The question is, do we want to keep the patients a bit dehydrated? I think it's a very clinical question. So maybe we can give the question to Dr. Wanhong Yin. Can you give us this kind of your ideas or your experience? Kind of dehydrated, so it's a 脱水 or something like that. So maybe it's not here. So I think Dr. Zhu Ren can give us some ideas.
Actually, as an ICU practitioner, we hate the word dehydration. So maybe we will use a principle of fluid restricted principle for our ARDS patient and for our respiratory failure patient. And for COVID-19 patient in Wuhan, as I heard from my friends who work there, and they all told me that for the early stage of COVID-19 patient management, almost most of the people are restricted from fluid. So that's the answer. So we are intentionally to do that, but if it is helpful for our patient, we don't know.
We have some ideas about this question. Because COVID-19 patients got respiratory failure is a key question, is a key point, is a key problem. The lung is a key organ of the injury organ. So during the hemodynamic management of the patients, fluid management is very, very important. So ultrasound, especially echocardiography, echo is very important for all these patients. When we have the question, have a problem to manage the fluid standards. So in the very beginning, you can choose the echocardiography to make maybe exacted and exact decision for the patient. Give some water, give lots of water, give hydrate water. So this is very important. So I think just like what we mentioned about the COVID-19 patient management, we use the critical ultrasound maybe routine. So this question is a good question for us. That's all.
Okay, thank you, Xiaoting, and thank you, Zhu Ran. And here is another question: is do you think that lung ultrasound can be a predictor for MV? I think I can take this question. If I were you, I would say yes, or probably yes. And the reason is, as Dr. Xiaoting gave us some information about this kind of image related to the COVID-19, is you say in the first stage, the patients, what happened with the lung is kind of interstitial syndrome. So we would say some A lines, lung pleural effusion, not pleural effusion, there's a sliding signs there, and also the whole lung is almost normal, but the later there will be the B line, B7 line, or B3 line, and according to the disease or the causes to be more severe, and the lung image more severe is become maybe white lung and even consolidation or lung pleural effusion, something in this kind of scenario. So if you use, I think this is the first part, and also you can see the disease or the image from the diaphragm, and also you integrate this information with maybe monitoring the vital sign observations, the temperature, and also some maybe blood gas like PCO2 or PO2, this kind of thing together. You will see the lung ultrasound could be the predictor to give the patients some help or the clinical diagnosis. And also, if you stand closer with the patients, you will see this kind of a trend or the change of this kind of image. If the patients from the normal condition more and more to the more severe condition, and maybe you will see some lower part of the lobe of the lung, you see some consolidation from B line or even from A line or lung sliding is in normal condition, and combine some very severe low blood oxygen pressure. And then I think you can imagine that it's very useful information to give you this kind of help to make the clinical decision. So that's why I say yes. How about your ideas?
Yeah, maybe Professor Tao. About this question, we have a little ideas about this. Just like because the virus is often inspired to the very deeply to the lung, so deeper and deeper, and the maybe the lung epithelium is invaded in the very beginning. So,
Yes.
so the subpleural lesion is often. So maybe in the very beginning, in the onset, we can do some lung ultrasound to compare with the CT scan and make an exact decision. It's the other reason to take a lung ultrasound examination for the patient in the very beginning. The other reason, because the subpleural lesion is very often. Okay. Professor Tao, there's another question about the ECMO. I think maybe Professor Zhu Ran can answer this question. How about the rate of the invasive ventilator and the ECMO implements in your departments? Is the ECMO effective for the critical cases? Maybe sometimes it will take a long time to get good results, or maybe the last results is not satisfied at all. Please.
Thank you for the question. I will take this. If you want to know the rate of the invasive mechanical ventilation and ECMO, from my experience, as I show the figures in our province at the beginning of my presentation, I only have 125 patients, almost 10 critical, only 3 critical COVID-19 patients and 2 on ECMO. So the ECMO rate for my patient is 2/3. And for invasive mechanical ventilation, maybe over 50%. And for this question, I just talked with my friends who worked in Wuhan Zhongnan University, and he told me that in his intensive care unit, as all the COVID-19 patients were critical COVID-19 patients, and the invasive mechanical ventilation rate may be over 60%, and the ECMO rate will be over maybe 10%. But I have to say it will depend on the machine. Do you have the machine, the environment, the experienced staff? And as I read from the news a few days ago, we can see that the whole country just sent about 400 ECMO machines to Wuhan to have them. So we could see the rate of ECMO will depend and will change after that. And if the ECMO is effective, it depends on your target of ECMO. And I think for the hypoxia and the support of the circulatory and respiratory system, definitely ECMO is effective. But it should have a longer process than some Euro case. For my patient, as I show to you, he was on ECMO for almost 30 days and is still going on. And the final result in our country, it is not statistic. Okay.
Hi, thank you. It's your turn, Professor Cao.
Okay. I think now is because of the time limitation. Now we just select the final question. Let me choose one of this. I think it's maybe it's for you, Dr. Xiaoting. Which best fluid responsive tools with so high PEEP? I think yours pioneers, expert in this area. You can give some answers for this question, and also you can conclude this our topic. Thank you, Xiaoting.
Maybe the concluding made by Professor Zhu Ran. I will answer his question. And the last chance for the lady. So I answer his question. Okay.
Okay.
Yeah.
Actually,
I will answer this question. Which best fluid responsive tool with so high PEEP, positive and aspiratory pressure? Okay, it's a very difficult question about the COVID-19 patients, because lots of patients have the high PEEP, just like about 15 millimeter centimeter H2O. So in these patients, we have very rare tools to evaluation the fluid responsiveness. So the echocardiography is the best one, because PEEP is very higher. So we do the echo for the patient. TTE is transthoracic echocardiogram is very difficult. There's a great window through the subcostal view. In the subcostal, we can require there's maybe five windows, 5 view about the heart and the IVC. So it's a great recommendation for the doctors to do the echo for the patient with so higher PEEP. There's maybe a 5-chamber view about the heart, and there's a IVC view. This 2 view is very important. Is the 2 key view about the patient to make to evaluation, to assess the fluid responsiveness. Maybe there's other views is important too, just like the short X about the aortic valve, and the other one, but not the least, it's very important about the main pulmonary artery view. We can see this view. It's in the patient with COVID with so high PEEP. So I recommend to the doctors on the lines, if you want to evaluation the fluid responsive tips, the first of all, that's very good, because in the every hemodynamic intervention, you should evaluate the fluid responsiveness. I recommend that the echocardiography is a good one. Is one good tool, and then subcostal view is the best one area to do the echo for the patient. That's all.
Okay, Dr. Zhu Ran, now it's your turn.
To make a conclusion.
Yes, thank you.
Okay, thank you, all my friends. As I quoted President Xi Jinping's words, no victory should be lightly announced until it is complete. So let's together wait for the final victory, and take care, all my friends from all over the world. And see you maybe the day after tomorrow. Thank you.
Yeah. Thank you. Bye. Take care.
Bye.
Take care. Safe and sound. Bye.